Welcome, dear learners. I have a question before you. Please listen carefully. A 67-year-old Chinese woman presented to the emergency department with a 3-day history of nausea and vomiting, palpitation, and chest discomfort. Her symptoms had started suddenly a few hours after eating lunch, beginning with the generalized weakness and the fatigue. She had noticed that her pulse was slow and irregular. A few hours later, chest pressure developed along with the abdominal cramping associated with nausea, vomiting, which persisted. The patient's medical history included hypertension, dyslipidemia, Meniere's disease, and asthma that were present from the earlier times. She was not taking prescription medications. Her supplement included vitamin B12, glucosamine, Chinese herbs like prepared licorice, dried Rahmania root, cinnamon twig, Ophiogone japonica, Ijao, hemp seed, jujube, and ginger. Her vital signs were notable for bradycardia, that is around 53 per minute. Other findings on the physical examination were normal. Results of initial laboratory investigations, including electrolyte levels, renal function, liver biochemistry, and synthetic function, were normal. Her serum potassium level was 4.1 millimole per liter and magnesium level was 0.96 millimole per liter. Complete blood count revealed a slightly elevated leukocyte count. Serial troponin level were not elevated. A chest radiograph was normal. An electrocardiogram ECG showed sinus rhythm with first degree arterioventricular block and sinus pauses of 1 to 2 seconds. The patient was admitted to the cardiac intensive care unit for monitoring. Then, over the next 4 days, recurrent dysrhythmias developed, including third degree AV block with accelerated junctional rhythm, sinus bradycardia, frequent premature ventricular contractions, non-specific ST segment changes, and T wave inversion in the lateral leads. On fourth day, a 30-second episode of monomorphic ventricular tachycardia was noted that prompted consideration for insertion for an implantable cardioverter defibrillator. The different ECG changes were noted and that is depicted in this picture. As you can see in different changes, sinus bradycardia and frequent premature ventricular contractions. The ECG changes that were presented to the patient were depicted on the photographs. The different types of presentation, sinus bradycardia, frequent premature ventricular contraction, non-specific ST wave changes, monomorphic ventricular tachycardia, T wave inversion, all these can be seen on the ECG leads. Then coronary angiography showed no substantial coronary artery disease and transthoracic echocardiography showed normal biventricular structure and the function. Then on the third day, patient's husband, aged around 66 years, presented to the same emergency department with similar symptoms. He had a medical history of dyslipidemia and was taking no prescription medication. Laboratory investigations showed normal electrolytes level, potassium 4.3 and magnesium 1.10. Renal function and complete blood count were in the normal range. Serial troponin level were not elevated and ECG showed sinus bradycardia with non-specific ST segment changes and lateral T wave inversion. There was no previous ECG for the comparison. In the emergency department, the husband was noted to have episodes of bradycardia with a heart rate of in the range of around 30s, and both patients reported visual disturbances described as flashing light and yellow or red halos around the object. On further questioning, the family brought in the plant specimen from their garden. As you can see in the picture, this plant that they ate along with the meal on the day of the event, and which were later confirmed that it is the foxglove plant. So that they ate before the presentation to the hospital. So now my question is, what is your diagnosis and how you will manage the patient? Although I cannot interact with you physically, but definitely I think you will be thinking that that monotherapy for the acute MI like thing could be there. So morphine, oxygen therapy, nitroglycerin, aspirin. So for the or blood digoxin level and the shall be checked, and the injection digoxin FB. Then the manage symptomatically thrombolytic percutaneous coronary interventions. Now you are clear with the presentation and the history and the way I told you that the patient presented with the foxglove plant. So by this time you will be searching what is a foxglove plant. So foxglove plant is basically the digitalis plant, that is the from where digoxin is obtained, and that is the cardiotoxic substance. So definitely to manage the almost all the presentation are around the cardiac symptoms are there. So you have to manage symptomatically, that we learned that symptomatic management we have to do. You may, if you would not be knowing exact the poisoning substance, then you may go for the treatment of the myocardial infarction, thrombolytics and percutaneous coronary intervention, morphine, oxygen therapy, nitroglycerin or aspirin. Although we have the report of the coronary angiography and echocardiography that are suggestive of normal findings, still in normally in our setup we usually don't go for that much of investigation for emergency patients. So in that situation we definitely would be managing symptomatically, but here the symptomatic management with that improvement is very less likely, because until the toxin that has been consumed is not neutralized, the chances of the recovery is very less. So for this patients, such patients, the best management in this case is the to assess the blood digoxin level, and then injection of the digoxin FAB antibodies shall be given, and the patient will come out of it very quickly, and it is the best remedy for this foxglove poisoning. So the this toxicology unit or toxicology center shall be having this digoxin FAB antibodies, because such type of poisoning not directly with the foxglove plant, but the some cardiotoxic drugs like digitalis or digoxin itself may be the factor for the presentation of the toxicity. So in those cases we need to manage the patient, and then we should have the availability of the detection of the digoxin level and giving the injection digoxin. So by this question you may guess what is the topic we are going to start today. Definitely by now you'd have understood that today we are going to learn cardiotoxic poisons. With this we will be starting the cardiac poisons. So the cardiac poisons are a variety of a number of things. All the drugs that are acting on the cardiovascular system can be used or can be the cardiac poisons when they are taken in the extra or excessive dose or given in the higher than the therapeutic level. So the cardiovascular drugs that you already know can be the diuretics, antihypertensive drugs, drug uses in the heart failure, anti-anginal drugs, anti-arrhythmic drugs, lipoprotein loading drugs. Then those are acting on the blood. They also can cause the different cardiac features that can be anticoagulant, antifibrinolytics, thrombolytic, antiplatelet drugs, hematopoietic growth factors. These are all included under the cardiovascular pharmaceuticals, and they all can be toxic for the heart in the depending upon the concentration. We will be not going in the details of them. Some of them we will be covering along with the pharmaceuticals. However, the toxicity and drug overdose, these are all covered in the pharmacology part of the your curriculum. So we will be more of concerned with the cardiotoxic plants, that is of our importance. The cardiotoxic substances that are occurring in the nature are innumerable. Among them, important to know for us is the tobacco, that is called Nicotiana tabacum. Then the foxglove plant that we already saw the case, Digitalis purpurea, white oleander, that is the Nerium odorum, then yellow oleander, Cerebra thievetia, then suicide tree, that is Cerebra odolum, and the aconite. These are the substances that is present naturally are of our interest. We will be learning each of them one by one. Then mechanism of action of those most of the cardiotoxic plants are almost similar. They contains the cardiac glycosides that act either of the following mechanism. That is, one is the inhibition of the sodium potassium adenosine triphosphate pump that causes increased level of intracellular sodium and decreased level of the intracellular potassium that is associated with hyperkalemia. And another mechanism could be the increased level of intracellular calcium that produces cardiac irritability and dysrhythmias, and they can increase the cardiac vagal tone, resulting in the decreased cardiac sympathetic activity that is presented as bradycardia and the heart block. So by either of the mechanism, all of these poisons that are acting on the heart are acting. So coming to the Nicotiana tabacum. Nicotiana tabacum, you very well know tobacco plant that is very commonly used all over the country in the form of the smoking, in the cigarette, or even the khani that is prepared by the villagers or the peoples around. Plantation of nicotine is done in form of the khani plant or tambaku plant all of in the fertile parts of the country. The plants, all parts are the poisonous except the ripe seeds. The dried leaves of the plant contains about 1 to 8% of the nicotine. The receptor, that is the nicotine receptor on the that act on the heart, and the nicotinic acetylcholinergic receptor, the name relate with that also. So nicotinic receptor, this nicotine compound, so it acts on the cholinergic nicotinic receptors, and in that way it produces the symptoms. So the active principle in the Nicotiana tabacum is the toxic alkaloids that includes the nicotine, anabasine, nornicotine. Fatal dose of the nicotine is around 50 to 100 milligram of the nicotine, that is fatal. Fatal period is 5 to 15 minutes. Then nicotine is a colorless, volatile, beetle and hygroscopic liquid alkaloids. Although we know its misuse, like that is done in the form of the tobacco smoking or in the form of the canny chewing, but it is, however, insecticidal purposes it is useful and used in the pesticides and worm powder in the agricultural lands. Then each cigarette contains about 15 to 20 grams of the nicotine, of which 1 to 2 grams are absorbed by the smoking. So you can think that this is the 50 to 100 milligram of nicotine is a fatal. Then each cigarette contains about 15 to 20 grams of the nicotine leaves, and of which 1 to 2 grams are absorbed by the smoking. So out of this 1 to 2 grams, around the actual nicotine content will be 1 to 8%. So that will be around 1 to 2 milligram of the nicotine in one cigarette. So the fatal dose is 20 milligram or 20 to 40 milligram. So if someone takes around 20 to 40 cigarettes at the same time, so it can be fatal for the in his health. Then the cigar, that is the larger form of the cigarette, that contains around 15 to 40 grams of the nicotine leaves. 80 to 90% of the nicotine that is consumed by the body is metabolized in the liver, and the remaining gets excreted from the urine. You can see the plant picture of the nicotine that has the inflorescence, flower, the leaves, fruits, the seeds, roots. So all the parts of the plant are poisonous except the seed part, that is not the poisonous. Then the mechanism of action, as we already talked, that it acts on the nicotinic receptors. So autonomic ganglia, which are stimulated initially, but later on it gets depressed and blocked at later stage. It also acts on the somatic neuromuscular junction and afferent fibers from the sensory receptors. So NM and NN junction, it acts. There it causes initial stimulation and then inhibition, resulting in the cardiac block and all those situations. Then in case of the acute poisoning with the nicotine, it will present with a burning sensation in the gastric mucosa, nausea, vomiting, abdominal pain, hypersalivation may be there. Then the cardiopulmonary symptoms could be tachycardia, hypertension, tachypnea. Then later on, after the inhibition of the centers, the bradycardia, hypotension, respiratory depression, and the cardiac arrhythmias may occur. Then in the CNS signs and symptoms will include the meiosis, confusion, headache, sweating, ataxia, agitation, restlessness. Late symptoms will include the mydriasis, lethargy, convulsion, coma, and finally death may happen because of the respiratory failure. You can see this is the picture of the dried leaves that is done in the agriculture area for the extraction of the nicotine. Then after that, in case of the chronic poisoning, the patient will have particularly those who are presenting with the chronic tobacco smoking, they will present with the cough, wheezing, dyspnea, anorexia, vomiting, diarrhea, anemia, faintness, tremors, impaired memory, amblyopia, blindness, extrasystole and arrhythmias. These all could be the symptoms and sign in case of the chronic poisoning. So a chronic tobacco smokers may have these of the clinical features on the later stage. Then when a continuous tobacco smoker withdraws from, then certain withdrawal symptoms that will present in them will be the intense urge to smoke, anxiety, impaired concentration and memory, depression or the hostility, headache, muscle cramps, sleep disturbances, increased appetite and weight gain, diaphoresis, rapid respiration. All these will be seen as a withdrawal symptoms. Then for the treatment of this withdrawal, that I think is important to know is the bupropion that is given for 12 weeks. And the dose of the bupropion is on the first 3 days, one tablet daily of about 150 milligram. Then from day 3 till the final stopping of the cigarette, take 2 tablets daily about 150 milligram each for at least 8 hours apart, and that shall be continued till the person is stable and the person no more needs the smoking for the relief of their symptoms. Till that, this bupropion shall be continued. Then for the management of the nicotine poisoning, the ABCDE that shall be completed, that should be stabilized, patient should be, all the immediate measures shall be taken. Then wash the stomach with a warm water containing charcoal, tannin or potassium permanganate. Then purging and colonic washouts may be applied. Mecalamine given orally is seen to be effective as it blocks the nicotinic receptors. Then protect the airways, and atropine sulfate is again the anticholinergic given 1 to 2 milligram intramuscularly. Hexamethonium chloride is also against the nicotinic receptor given 25 to 50 milligrams subcutaneously. Then certain vasodilators because it causes vasoconstriction. Then oxygen and other symptomatic cares will make the patient survive. In this way, the acute management of the patient is done. Then in case of death, the body is sent for the postmortem examination as a poisoning measures. So all the steps of the poisoning that is routinely performed shall be done, the samples that shall be preserved. There is nothing very specific finding related to the nicotine poisoning that will be seen on the patient. Clinical report will be very helpful to correlate with the cardiac finding and all the other finding. On the postmortem examination, the signs of asphyxia will be prominent, that will be congestion, petechial hemorrhages, cyanosis, all these could be there. Then brownish froth at the mouth and the nostrils could be seen as a large quantity of nicotine shall be consumed to produce the symptoms. So the content, stomach content will be the brownish in color. Then hemorrhagic congestion of the GI tract could be there, pulmonary edema and the fragments of the leaves in the stomach will be very suggestive of the nicotine poisoning, and the samples that shall be preserved for the toxicological analysis, and there it will be detected for the compound. So in this way, autopsy in case of poisoning with the tobacco shall be done. Thank you.